Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We have a Telegram group which you can join and is very helpful for accessing all lecture related information. We also have a Google Drive where the PDF of all lectures are uploaded. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we have Pursue 26K, which is Dermatopathology. And we are streaming from AIIMS, Bhubaneswar, India. And the topic of the day is Perivascular Dermatitis. And to talk on that, we have Dr. Pavithra A. She's an MD from JIPMER, a DNB. Presently, she's an assistant professor in the Department of Pathology and Lab Medicine, AIIMS, Bhubaneswar. Her areas of interest is dermatopathology, surgical pathology, and nephropathology. She's got more than 55 publications in international and national journals. With that, I would request Dr. Pavithra ma'am, please start your lecture on perivascular dermatitis. All yours. Thank you so much.
Good evening, everyone. I will discuss the topic perivascular dermatitis. I will discuss it under the following headings. First, the definition, classification, common and rare entities, clues to differentiate the perivascular dermatitis, the discussion about each entities with their clinical features, pathological features, and the differential diagnosis, and finally, the approach to the perivascular dermatitis. Perivascular inflammatory dermatosis. This constitutes a group of dermatoses characterized by a predominantly perivascular inflammatory infiltrate. These can be broadly classified into two subtypes, superficial perivascular inflammatory dermatosis and superficial and deep perivascular inflammatory dermatosis. Superficial perivascular dermatitis. These are the conditions associated with infiltrates of lymphocytes around the vessels of the superficial capillary venular plexus with or without other cell types. The epidermal changes are variable. Here we can see superficial perivascular dermatitis involving the upper and mid dermis. On higher magnification, we can see the inflammatory cell population is lymphocytes. Superficial and deep perivascular dermatitis. These are the conditions associated with infiltrates of lymphocytes around the vessels of the superficial and deep capillary venular plexus with or without other inflammatory cell types. Here we can see both superficial and deep perivascular inflammation. Deep, here we can see the lower dermis and the subcutaneous area with perivascular lymphocytic infiltration. So first we'll see the common and rare entities of superficial perivascular dermatosis. The common entities are viral exanthem, pityriasis rosae, pigmented purpuric dermatosis, urticarial vasculitis, chronic superficial dermatitis, drug rash, atopic dermatitis, candidiasis, and CLE. The rare entities are Erythema annulare centrifugum, Erythema gyratum repens, Reticular erythematous mucinosis, and radiation dermatitis. Next is superficial and deep perivascular dermatosis. Under this, the common entities are polymorphous light eruption, arthropod bite reaction, chronic cutaneous lupus erythematosus, and syphilis. The rare entities are Jesner's lymphocyte infiltrate of the skin, chilblain, borreliosis, pseudolymphoma. These are the clues to differentiate between various perivascular dermatosis. First is based on the location, whether it is confined to the superficial dermis or is it both superficial and deep perivascular location, associated perineural, periacrine and perifollicular inflammation, involvement of subcutaneous. Next is the based on type of inflammatory infiltrate. Then the associated epidermal changes like spongiosis, epidermal atrophy, psoriasiform proliferation, lichenoid dermatitis, and dyskeratotic changes. And finally, the associated dermal changes like dermal edema. For example, here we can see superficial perivascular inflammation. And on higher magnification, the inflammatory infiltrates of moderate intensity involving the upper and mid dermis. And the type of inflammatory cell is mast cell, which are highlighted by CD117 IHC. So it is a case of cutaneous mastocytosis. So next is the perivascular dermatitis associated with major reaction pattern. First is the psoriasiform dermatitis. It is seen in psoriasis, prurigo nodularis, lichen simplex chronicus, and chronic eczema. Second is lichenoid pattern of injury, seen in lichen planus and lichen nitidus. Third is spongiotic dermatitis. It is seen in acute or subacute eczema. Vasculitic pattern is seen in urticarial vasculitis, and the vesiculobullous pattern of lesion seen in pemphigus vulgaris and bullous pemphigoid. First, we'll discuss the entities under superficial perivascular dermatitis. So the most common entity is viral exanthemata. These are the cutaneous eruptions caused by the viruses, which are due to immune complex mediated disease or cell mediated hypersensitivity reaction. And the most common viral etiologies are CMV, enterovirus, EBV, hepatitis B, HIV, paramyxovirus, parvovirus, rubella, and roseola. So it is a case of viral exanthem. We can see here the superficial dermis shows perivascular inflammation, and the type of inflammatory cell is here lymphocyte. Next is the pityriasis rosea. So clinically it presents as a herald patch followed by disseminated eruptions. These are round to oval salmon colored patches following the lines of cleavages, and peripheral thin cigarette paper like scales resembles Christmas tree pattern. The most common sites involved are trunk, neck, and the proximal extremities. These are the early lesion called herald patch, and the later it will show multiple scaly lesions resemble Christmas tree pattern. Histopathological features are mounds of parakeratosis known as salute sign, mild to moderate acanthosis, spongiosis, and lymphocytic exocytosis, superficial perivascular infiltrate comprising of lymphocytes and histiocytes, extravasated RBCs in the upper dermis, rarely dyskeratotic cells and eosinophils. The later lesions can show psoriasiform pattern and more number of eosinophils. Here we can see the superficial perivascular inflammation, and on higher magnification we can see the mounds of parakeratosis and moderate acanthosis with mild perivascular lymphocytic infiltration. In this picture you can see the perivascular inflammation comprising of lymphocyte as well as few histiocytes. And here we can see the upper dermis with extravasated RBCs. So the differential diagnoses are maculopapular drug rash and erythema annulare centrifugum. The next entity is pigmented purpuric dermatosis, PPD. It encompasses a number of clinical syndromes characterized by orange or brown pigmentation interspersed with fine pinpoint purpura, and all these syndromes are of unknown etiology. These are the 5 diseases under PPD. So in skin of color we can see the tiny brown pigmentation, and on dermoscopy we can see multiple pinpoint this dilated vascular channels. All these subtypes of PPD show similar histopathological features. Those are perivascular lymphocytic infiltrate of varying density, reactive endothelial changes, extravasated red cells, and in case of lichenoid variant will show band-like lymphocytic infiltration in the upper dermis. The early lesions will show extravasated RBCs, and the later lesions will show hemocyte-related macrophages, which are highlighted by pearl stain. Granulomatous PPD, it is associated with hyperlipidemia. So in this picture, we can see the perivascular lymphocytic inflammation. In addition, we can see the extravasated RBC. It is an early lesion, and here we can see the dense lymphocytic infiltration. So the later lesions will show hemosydin-laden macrophages, which are highlighted by pearl stain. And in this picture, we can see lichenoid pattern of infiltration, which is a band-like lymphocytic infiltration in the upper dermis. So the differential diagnosis of PPD are other forms of perivascular lymphocytic infiltrate and lymphocytic capillaritis. The second is mycosis fungoides. Mycosis fungoides will be differentiated by the presence of epidermotrophism and the cytological atypia of the lymphocytes. And the second, we can differentiate by the immunohistochemical features and T-cell rearrangement studies. It is a case of mycosis fungoides. Here we are seeing the upper dermis with atypical lymphoid cells which are infiltrating the overlying epidermis known as epidermotrophism and the lymphocyte tagging along the basal layer. And these lymphocytes will show cytological atypia. The next entity is Urticarial vasculitis. It is a type of cutaneous small vessel vasculitis characterized clinically by urticarial plaques and histologically by leukocytoclastic venulitis. Associated features are angioedema, arthralgia, gastrointestinal symptoms, and evidence of renal involvement. It is common in female and in young adults. The histopathological features are leukocytoclastic vasculitis with features of fibrinoid necrosis, leukocytoclasia, and vessel wall destruction, RBC extravasation, endothelial swelling, and perivascular neutrophilic or lymphocytic infiltration. It is a picture of urticarial vasculitis. Here we can see the upper dermis with the extravasated RBCs. On higher magnification, this vessel wall shows evidence of leukocytoclastic vasculitis with the endothelial swelling and fibrin deposition, and it also shows extravasated RBCs and associated perivascular dense neutrophilic infiltration. However, many times the fibrinoid necrosis and leukocytoclasia may be minimal or absent. A perivascular lymphocytic infiltration along the RBC extravasation and endothelial swelling favors urticarial vasculitis. So a clinical pathological correlation is very important. So it is a case of urticarial vasculitis. Here we can see the moderate degree of perivascular inflammation. These are the lymphocytes around the capillaries and RBC extravasation. So it is a case of urticarial vasculitis. The next entity is chronic superficial dermatitis. It is also known as digitate dermatosis, superficial scaly dermatitis, small plaque parasoriasis, persistent superficial dermatitis. It presents as asymptomatic round to oval erythematous scaly patches. Often they have finger-like appearance known as digitate dermatosis, are associated with a fine cigarette paper scale which are pale white in color. It usually affects limb and trunk and it's seen in middle-aged adults. The histopathological features are upper and mid dermis with perivascular lymphocytic infiltration. It can show various epidermal changes like parakeratosis, acanthosis, and spongiosis. And these lymphocytes predominantly CD4 positive. Few can show CD8 positivity. CD2, CD3, and CD5 are positive. CD7 expression is variable. It can be negative. The differential diagnoses are delayed type hypersensitivity, viral exanthem, connective tissue disease, mycosis fungoides, and pityriasis lichenoides. Mycosis fungoides We can differentiate by the clinically by the presence of variable size, shape and color of the patch, which is uniform in chronic superficial dermatitis, and histopathologically presence of spongiosis favors chronic superficial dermatitis, and the presence of atypical lymphocyte epidermotrophism and the immunohistochemical features favors mycosis fungoides. Next is the pityriasis lichenoides. It will be differentiated by the presence of spongiosis. If it is present, it favors chronic superficial dermatitis, and interface changes are common in pityriasis lichenoides. The next entity is Erythema annulare centrifugum. It affects all age groups and common in young adults. The most common sites involved are thigh, trunk and upper extremity. It can show relapses and remission. So here we can see well circumscribed annular erythematous band with raised edge and trailing scale. The histopathological features are the superficial dermis with well demarcated perivascular lymphocytic inflammation. It can show admixture of histiocytes. On higher magnification, here we can see the well demarcated perivascular lymphohistiocytic inflammation resemble coat sleeve appearance. So the differential diagnosis of this entity are psoriasis. It will be differentiated by the presence of parakeratotic mound associated with neutrophils. And the second entity is cutaneous lupus erythematosus. It will be differentiated by the presence of interface changes and positive direct immunofluorescent findings. Third is the erythema chronicum migrans. The presence of plasma cells, special stains and PCR for spirochetes favors erythema chronicum migrans. The other DDs are other gyrate erythema, pityriasis rosea, hypersensitivity reactions, viral exanthem, Jester's lymphocytic infiltrate, and fungal infections. Next entity is Erythema gyratum repens. It usually associated with an underlying malignancy such as carcinoma lung, uterus, cervix, esophagus, stomach, and kidney. The remission and relapse of the cutaneous eruptions were depending on the treatment or the recurrence of the malignancy. So these eruptions are concentric bands of erythema in an annular or gyrate arrangement, resemble tipper grain or zebra-like pattern. The erythema is migratory and associated with scaling. Common sites involved are arm, leg, and it's common in elderly male patients. The histopathological features are superficial perivascular lymphohistiocytic infiltrate, and the epidermis will show hyperkeratosis and acanthosis. The next entity is reticular erythematous mucinosis. It is common in female of middle-aged patient. It presents as a persistent reticulate attecated macular and papular erythema with an irregular and well-defined border. The most common sites involved are central chest and upper back. The histopathological features are perivascular lymphohistiocytic inflammation involving the upper and mid dermis and associated perifollicular inflammation. On high magnification, here we can see in addition to the perivascular inflammation, there is perifollicular lymphohistiocytic inflammation. And the another important finding is increased dermal mucin, which separates the collagen fiber, and it is highlighted by algin blue stain. So the differential diagnosis of this entity are lupus erythematosus. The presence of epidermal changes like hyperkeratosis, follicular plugging, basal vacuolar degeneration favors lupus erythematosus. Positive DIF findings and the clinical serological correlation. The second differential diagnosis is polymorphous light eruption. Here we can see less mucin deposition and the lesion here confined to the papillary dermis. There is no perifollicular inflammation, presence of spongiosis. These features favors polymorphous light eruption. The third differential diagnosis is lymphocytic infiltrate of JIPMER. The absence of mucin deposition and prominent lymphocytic infiltration favors this entity. So this is a case of cutaneous lupus erythematosus. Here we can see atrophic epidermis and with hyperkeratosis, and the basal vacuolar degeneration with cytoid bodies, and the upper dermis shows perivascular lymphocytic inflammation. Here we can see the dermal mucin deposition, and these mucins can be seen around the follicular region. Now we will discuss about the entities of superficial and deep perivascular dermatitis. The most common entity is polymorphous light eruption. It is a photodermatosis. It is common in young female. The most common sites involved are face, chest, upper back and extremities. It affects both fair and dark skinned patients. It usually shows multiple erythematous papule, vesicle and plaque following exposure to ultraviolet light. The most common symptom is pruritus. In skin of color or dark skinned individual, vesicle is not a prominent feature. Multiple pinpoint shiny papule usually group together and it will form a scaly plaques. These are the pinpoint papules, and here we can see the scaly plaques. The histopathological features are dense, the upper, mid as well as the lower dermis inflammation, and the papillary dermis will show edema and extravasated RBCs. On immunofluorescence studies, weak positivity along the basement membrane zone for C3, IgG and IgM can be seen. In skin of color, dermal edema is not a prominent feature. It is a polymorphous light eruption in skin of color patient. Here we can see the upper dermis shows perivascular inflammation, but the dermal edema is not a prominent feature here. On higher magnification, we can see perivascular inflammation in the upper dermis. The differential diagnoses are reticular erythematous mucinosis. It will be differentiated by the presence of excess dermal mucin and persistence of the eruption after cessation of the exposure to sunlight. The second differential diagnosis is lymphocytic infiltration of JIPMER. Here we can see there is absence of papillary dermal edema, persistence of the eruption after cessation of the exposure to sunlight, and the negative photo testing result. The third differential diagnosis is lupus erythematosus. This will show strong positivity for DIF, and it needs clinical and serological correlation. And the last differential diagnosis is actinic reticuloid. It is also associated with exposure to ultraviolet light. Histopathologically, it shows dense cellular interstitial infiltrate involving papillary and reticular dermis. It can involve subcutis, and it is composed of lymphocytes, histiocytes, variable number of eosinophils, plasma cell, multinucleated stellate myofibroblast, and giant cells. And these lymphocytes will show atypical features. The next entity is Tumid lupus erythematosus. It is a subtype of chronic cutaneous lupus erythematosus. Clinically present as raised, succulent erythematous plaques, or it can show annular and gyrate forms in some patients. And the it commonly affects the face, chest, arm, and shoulder, and it is seen in young adults. The lesions occur after exposure to ultraviolet light or following therapy, like following highly active antiretroviral therapy, estrogen, and infliximab treatment. The histopathological features are superficial and deep perivascular lymphocytic infiltration. Here we can see periadnexal involvement, abundant dermal mucin, and it will not show the epidermal changes of cutaneous lupus erythematosus. The direct immunofluorescence findings will be negative. The differential diagnoses are Jersner's lymphocytic infiltrate. It will be differentiated by the absent HLA-DR stain in these lymphocytes and presence of LEU8 positivity in these lymphocytes, and the epidermal Langerhans cells are increased and absence of dermal mucin. These features favors Jersner's lymphocytic infiltrate. The second differential diagnosis is polymorphous light eruption by the presence of dense perivascular lymphohistiocytic infiltrate, papillary dermal edema, focal spongiosis, and absence of dermal mucin favors PMLE. The next differential diagnosis is erythema annulare centrifugum. Here it will show absence of significant dermal mucin. Next entity is chilblain lupus erythematosus. It is a manifestation of either discoid lupus erythematosus or systemic lupus erythematosus, and it shares many clinical and histological similarities with idiopathic chilblains. It exclusively seen in female during winter months. It presents as itchy, painful, erythematous or blue-purple papule, plaques, or nodules. And it usually involves fingers, heels, and soles of the feet. Hyperkeratotic fissured lesions and ulcers can be seen. The histopathological features are perivascular lymphocytic infiltration, which are predominantly T lymphocytes. Few macrophages and B lymphocytes can be seen. Edema will be there. Extravasated RBCs, variable vascular fibrinoid changes, lymphocytic vasculitis, and the chronic inflammation around the sweat glands. The differential diagnoses are lymphocytic vasculitis. It will be differentiated by clinical and serological correlation. The second differential diagnosis is idiopathic chilblain perniosis. Here the DIF findings will be negative and there is absence of anti-nuclear antibodies. Next, coming to the Jersner's lymphocytic infiltrate of the skin. It is associated with sun exposure and the lesions are single or multiple, discoid, annular, erythematous, papules, plaques with a central clearing, and these lesions are usually asymptomatic. It is seen in the sun exposed areas like face, neck, back, and upper chest. It is common in 3rd to 5th decade of life. The histopathological features are superficial and mid-dermis, perivascular and perifollicular lymphocytic infiltration admixed with few histiocytes and plasma cells. On higher magnification, here we can see there is a dense perivascular lymphocytic inflammation. Here we can see perifollicular inflammation. And these lymphocytes are CD4 positive, LEU8 positive, but HLA-DR will be negative. The differential diagnoses are, first is discoid lupus erythematosus. It will be differentiated by the epidermal, dermal and the immunohistochemical features. First is the epidermal changes like hyperkeratosis, follicular plugging, which will be seen in case of DLE, and the epidermal Langerhans cells will be decreased in case of DLE, increased in cases of Jersner's lymphocytic infiltrates. Scarring, telangiectasias favors DLE, and the immunohistochemistry of the inflammatory infiltrate, which are predominantly T cell population in case of Jersner's lymphocytic infiltrate, mixture of B and T lymphocytes seen in discoid lupus erythematosus. And these lymphocytes will be negative for HLA-DR in case of Jersner's lymphocytic infiltrate, whereas it is positive in DLE. LEU8 antigen will be positive in Jersner's lymphocytic infiltrate. And plasmacytoid monocytes favors Jersner's lymphocytic infiltrate, and the presence of dermal mucin favors DLE. The other differential diagnoses are CLL. It will be differentiated by the cell morphology and the immunohistochemical studies. The reactive lymphocytes will show small, regular and hyperchromatic nuclei, whereas the CLL, neoplastic lymphoid cells, are larger, irregular and pale staining nuclei. It can show nucleolus. The other differential diagnosis, PMLE, it will be differentiated by the presence of papillary dermal edema, spongiosis and positive photo testing. Then finally, reticular erythematous mucinosis. It will be differentiated by the presence of mucin deposition and milder degree of lymphocytic infiltration. The next entity is periniosis. It is characterized by sensitivity to the cold and damp weather. It presents with painful erythematous nodule, blister formation or ulceration. The most common sites involved are distal extremities, that is fingers and toes. Nose and ears also be affected. It remits during summer but often recurs during the winter months. The histopathological features are superficial and deep perivascular lymphocytic infiltrate, variable vascular fibrinoid change with the thrombus formation, papillary dermal edema and interface changes can be seen. The chronic inflammation can be seen around the sweat glands and cold paniculitis. Here the perivascular chronic inflammation is seen at the dermal and subcutaneous junction. These are the histopathological features. The epidermis shows hyperkeratosis, acanthosis and marked subepidermal edema and extravasated RBCs. And here we can see predominantly perivascular lymphocytic infiltration and extravasated RBCs. The next entity is pruritic urticarial papule and plaques of pregnancy. It is a dermatosis of uncertain etiology, usually seen in primigravida at the end of first trimester. It involves the proximal limbs. It presents as pruritic urticarial papule and plaque and it resolves after delivery. And the histopathological features of early lesions show epidermal and upper dermal edema, perivascular lymphohistiocytic infiltrate with variable number of eosinophils, and mild papillary dermal edema. The late lesions will show spongiotic vesiculation. The differential diagnosis of this entity is urticaria, hypersensitivity reaction and pemphigoid gestationis. Now we will see the approach to various perivascular dermatitis. Superficial perivascular dermatitis with the inflammatory cell population predominant is lymphocyte. Most common is viral exanthem. If eosinophils are predominant, seen in arthropod bite reaction, neutrophils are predominant in erysipelas. Plasma cells are predominant in case of secondary syphilis. Extravasated RBCs seen in pigmented purpuric dermatosis and pityriasis rosea. Siderophages are seen in pigmented purpuric dermatosis. If the predominant cell population is mast cell, it favors telangiectasia macularis eruptive persistens. It is a case of secondary syphilis. Here you can see perivascular, lymphocytic and predominantly plasma cells. And it is a case of insect bite reaction. Here, in addition to the lymphocyte, the predominant inflammatory cells population here is eosinophils. Next is superficial perivascular dermatitis associated with spongiosis and the lymphocyte predominant inflammation. Example is nummular eczema. If eosinophils are predominant in cases of allergic contact dermatitis, if neutrophil is predominant, it favors seborrheic dermatitis. If plasma cells are predominant in case of secondary syphilis. And these superficial perivascular dermatitis with epidermal atrophy, and the inflammatory cells are very scant, it favors radiation dermatitis. Along with these features, if lymphocytes are predominant and also the papillary dermal sclerosis is present, it favors lichen sclerosis at atrophic. Next is superficial perivascular dermatitis. If it associated with epidermal psoriasiform proliferation and the predominant inflammatory cell is lymphocyte, it favors chronic atopic dermatitis. And if the inflammatory cell is neutrophil predominant, in case of psoriasis vulgaris. It is a case of atopic dermatitis. Here we can see the epidermal proliferation with the upper dermis shows perivascular lymphocytic infiltration. On higher magnification, we can see the predominant cell population is lymphocytes in the perivascular location. It is a case of psoriasis. Here we can see the regular elongation of reticular with the upper dermis shows perivascular inflammation. Here the predominant cell population is neutrophils in addition to lymphocytes. Next is superficial perivascular dermatitis. If it associates with irregular epidermal proliferation and the lymphocytes are the predominant inflammatory cell, it favors prurigo nodularis, or the neutrophils are the predominant cell population in case of impetigo contagiosa. So it is a case of prurigo nodularis. Here we can see the hyperkeratosis, papillomatosis, hypergranulosis, and irregular proliferation of the reticular with a moderate degree of acanthosis. And these upper dermis and the mid dermis shows perivascular lymphocytic infiltration. Next is superficial perivascular dermatitis. If it is associated with a lichenoid pattern of infiltration and it shows only lymphocyte, it favors lichen planus. And the lymphocytes are the predominant cell population in case of lichen planus like keratosis. In addition to lymphocyte, if eosinophils are predominant in case of lichenoid drug eruption, if melanophages are prominent in case of post-inflammatory hyperpigmentation. If histiocytes are predominant, it favors lichen nitidus. Next is superficial perivascular dermatitis associated with the basal vacuolar degeneration of the epidermis and the presence of apoptotic cell favors erythema multiforme. If apoptotic cells are absent, it favors dermatomyositis, and the variable number of apoptotic cells favors cytotoxic drug eruption. In addition to these features, if basal membrane thickening is present, it favors cutaneous lupus erythematosus. And the dermal edema favors PMLE, polymorphous light eruption, and peroneosis. So the take-home messages are: perivascular inflammatory dermatosis comprises a vast group of disorders that can occur in isolation or in association with other reaction patterns. The diagnosis and differentiation of various isolated perivascular dermatoses from each other is vital from the prognostic point of view. A detailed examination of the pathological clue to various perivascular dermatoses is essential in making the correct diagnosis. However, thorough clinical knowledge and a clinical pathological correlation is mandatory for the final diagnosis. These are my references. Thank you.